All right, good morning, everyone. We'll go ahead and call this meeting of the Healthcare Consumer Protection Advisory Commission to order. And I will start with a motion to accept the minutes from our February 9th, 2026 meeting.
So moved.
Have a second? All those in favor, please say aye. Aye. Any opposed? All right, and the minutes are adopted. Sorry to everyone that we had to cancel our last meeting. We've been sort of snake bit with this commission. We've now lost a couple meetings due to snow, but we're moving into spring soon enough, so hopefully that will abate. In the interest of time, I'm just going to jump right into the first primary item on our agenda today, which is to get an update from Dr. Herring on the work of the UNH Center for Studying Healthcare Markets, which we're all very excited about. So, Doctor, I'm going to turn it over to you.
Okay.
And then I have to pop out for a second, so please don't take that
Okay.
personally, but I'll be right back. But you could
Okay.
take
Thanks for having me back. Eager to talk to you all about our progress since we got to go ahead to receive funding. I thought what I might do at first is just kind of summarize our proposal that you funded, given that there's a few new commission members, and it might help to kind of set the stage for like all that we're planning on doing, and then I'll kind of transition into what we've done over the first year. And in some sense, when I get there, I'll reference the website we created that I understand you've been sent a link to, and again, kind of describe what's currently there, and then also talk about our plans for what's to be added over the next 3 years or so. Okay, so if you don't know, so I'm Brad Herring. I'm a professor of economics with a joint appointment in health policy management at University of Hampshire, now director of the Center for Studying Healthcare Markets. And this proposal essentially had 3 overarching aims. The first aim to look at healthcare market consolidation for New Hampshire, both compared to surrounding areas, but also trends over time. And then in turn, kind of translate what we observe for market concentration to outcomes like prices, premiums, access to care. And so within that, we kind of started off by looking at hospital market consolidation with plans to, in the future, look at insurance market consolidation and physician market consolidation. So that's essentially like the snapshot of our aim 1, right? Accomplish those things with policy briefs that are trying to be a little, less technical, researchy oriented. Whereas the second aim of the proposal is to do kind of like more academic oriented research, building on large literature that's looked at the effects of healthcare consolidation, where our goal is to try and start looking at some understudied outcomes, right? So for instance, there's a pretty large literature establishing the connection between hospital markets and consolidation and hospital prices. So we didn't really feel like the need to kind of like reinvent that wheel, but instead kind of eager to look at certain things that again have largely been understudied. And so in our proposal that you funded, we identified 6, all related to hospital markets, but kind of eager as time goes on, as we develop this infrastructure and get new ideas, to look at more things, right? More things in the hospital market area, but also more things looking at insurance market consolidation and physician market consolidation. And so the third aim is, as we're building this pretty large infrastructure for hospitals, physicians, and insurers, we'd like to in turn be able to be like a resource to you all as things come up and you might, want some help, right? And so we've been amassing a lot of data. We've still got more work to do in terms of pulling more things in, but we'd like to be helpful in that regard. Okay. So with that kind of backdrop in terms of like what the proposal was that again you all funded, over the past year we've created this website, right? First kind of had to launch kind of talking about what we plan to do, and then over the past couple months had the policy brief looking at hospital market consolidation here in New Hampshire. And so if you were here when I presented, I think it was October, it was kind of walking through a slide deck that had what we were about to post online. And so in the month or so after I presented here in October, it went live. And then a few months later, we kind of added like a second half, which then talked about what the implications of those changes in hospital market consolidation might mean. And so happy to kind of talk a little bit about that specific policy brief if you're interested, but in terms of like an overall goal, you know, if you go to the website, you kind of get to this landing page. Up top, you can click a link for hospital markets, and you see this policy brief with our graphics and the discussion. And the goal is that over time, we'll add a new one for insurers, with kind of like a similarly structured policy brief, and then over time, add a new one for physician markets, similarly structured policy brief, and then in turn, kind of update those over time, right? New American Hospital Association data gets released, we'll update it with 2024 estimates, and maybe stretch it out to talk a little bit about maybe some other outcomes that we haven't talked about, maybe make some things clear that may not be that clear in our first go around at this. Yeah, so that's kind of the plan in terms of the AIM 1 things. For the AIM 2, right, these research papers, kind of a deep dive, we posted our first one, which is, albeit pretty dense, 40-page, single-spaced analysis of electronic health records. So a couple minutes ago, I kind of tried to make this pitch that we're going to try and look at, understudied outcomes as a result of hospital market consolidation, looking at hospitals opening and closing service lines, looking at nonprofit community benefits, looking at electronic health records. Outline the 6 if you're curious. But this electronic health record one, I think we're pretty excited about what it kind of implies, right? So you may not really be that interested in electronic health records per se, right? But I think generally, right, if you're kind of interested in hospitals consolidating and on one hand being concerned that they face fewer pressures, competitive pressures to lower prices or improve quality, but at the same time, hear the hospitals kind of say, well, this consolidation is going to allow us to be bigger and more efficient and potentially, enact quality improvement initiatives. Our study of electronic health records actually kind of documents both of those phenomenon. So we're kind of simultaneously able to look at the effect of the competitive market pressure through these Herfindahl-Hirschman indices that I've kind of talked about in the policy brief, but at the same time kind of compare smaller hospital systems to larger hospital systems, and indeed kind of document that these two things are kind of happening, right? The competitive pressure is leading hospitals to be less inclined to adopt more advanced electronic health records, which, in other research, actually has important clinical implications. But on the other hand, the consolidation actually does enable a larger system to have the resources to adopt a more advanced system. And so there's kind of this tension, which we think in turn has a lot of implications, which in some sense are things you've already been pursuing, which is, to be a little concerned about within market mergers, because that's really just, the downside of, lack of competitive pressure, but potentially be, a little bit open to the cross-market mergers where the competitive pressure isn't necessarily an issue, and then you can potentially have some of these gains from consolidation. So again, that paper, we posted that to the website probably 3-4 weeks ago, and the goal there is over the next several years, keep posting these research papers where we're kind of doing a deep dive on, again, kind of these understudied outcomes. And so I think the next one that's kind of in the works, all of them are in the works, but the one that's probably closest to being posted is the analysis looking into hospital service lines opening or closing, right? The thought that maybe a merger, an acquisition, kind of leads a hospital to perhaps focus on the more profitable service lines and the detriment of less profitable service lines. So we're kind of eager to look at those questions. And again, other ones, looking at some hospital quality measures, looking at community benefits from nonprofits, looking at the nonprofit bond market. It's actually like what we think is kind of a clever way to look at the financial strength of a nonprofit hospital, since a lot of more traditional financial measures really wouldn't apply. And with that, yeah, I'll kind of stop and be eager to kind of hear your reactions, answer any questions you have. And also kind of happy to talk about data if you're interested, but yeah, we've been working a lot on compiling a bunch of stuff. Yes.
Thank you, Doctor. I have a couple questions, and apologies if you mentioned either of these things while I was out of the room. The first is just, what are you doing to sort of publicize the fact that you published a paper and put it on your website? And I'm wondering if maybe we could help with that, because we want people to know this is happening and that paper is there. And,
for sure.
And
yeah.
what you guys are producing. So could you talk a little bit about that?
Yeah. So I think the short answer is probably not enough. And in turn, I think we would definitely benefit from your assistance, right? So having said that, I know the UNH social media team and publications group. I mean, they're eager to do more than what we've done already. But I think, so far there's been some stories that they've done, and I think in some sense we're also kind of thinking about like waiting a little longer until there's a little bit more detail on the website, because like right now it's really just like the hospital market consolidation brief, and I guess we should be working to get that out there, but in some sense we're also kind of eager to be the point when there'll be a little bit more information there.
Okay. Yeah, maybe we could, even if we put out like a release just with that paper, I just want to make sure people are seeing this stuff, right?
Sure.
And that's also a good way to get feedback, because if everybody looks at it and says, well, thank you for that, but we already knew all that. Like,
right.
I'm not saying that's what's going to happen, but like the more eyes are on this, I think the better feedback you'll get, and we'll all get.
I definitely agree. Thanks.
Okay. Another question: just, are you looking at other states, or what maybe what your counterparts at universities or other think tanks are doing in other states on this stuff to help inform like how you approach it?
In some sense. Other states, in the sense that a lot of this research has focused on, using nationally representative data, looking at what happens in certain areas and others, and some studies do focus on other states. But in terms of, so counterparts at other universities who are interested in these issues, talk to them all the time, share papers, read their papers, all that kind of stuff. But candidly, I'm not really aware of any other universities that are doing kind of like a similar focus on consolidation in their state.
Yeah. Okay. No, I mean, in some ways that's good to hear, right? That we're doing something innovative. But
I think so. Yeah.
But I'd also suggest that you guys, take a little time to survey that and figure out whether anyone's doing anything similar and whether there's any notes we could be comparing. And then just one last question. I know in your proposal you had kind of laid out the team, and maybe you talked about that at the beginning but could you just remind us of who you're working with?
Sure,
who your team is?
Okay, so we have 5 professors at UNH, myself as director, 2 professors in the business school. One is also a health economist like me, junior faculty, so it's going to be a lot more up to date on methods than perhaps I am. That's Ben Zhu. And then Linda Ragland is an accounting professor who has a lot of expertise in nonprofits. And so one of the things we're especially interested in is the effect of consolidation on nonprofit hospitals in particular. So those are the 3 of us that sit in the business school. And then there are 2 professors that sit in the health management and policy department. Semra Achor, who's an epidemiologist who has a lot of clinical expertise and thinks about access to care a lot. And then Ishmael Balkari, who's systems engineer, who has a lot of background in researching hospitals. And then on top of that, we have PhD students. So one of the things I talked about is we are bringing in PhD students to have them utilize these data, work on the research projects during their third, fourth, and fifth years of their PhD program. So they do their coursework for the first two, and then they bring them in. And so right now, we have our first two students, Fahima Esperaldi, who's co-author with me on that electronic health record paper, and Maria Gomez, who's a third-year PhD student, working a lot on that hospital service line analysis that we're starting. And then so the third PhD student will start this summer, and then another student coming in the following summer. So the thought is we kind of have this cycle of more junior, more senior students kind of cycling through during the final 3 years of their PhD program.
Okay, great. Other questions for Dr. Aaron? Yeah.
Thank you so much for your work. Appreciate it. It was an interesting read. I probably didn't get all 40 pages of it, but most of it.
I'm happy you tried. Yeah.
So my question is, how do you use that, the conclusions? First of all, maybe you can share for some of the folks in the room that haven't gone through 40 pages of it.
Sure.
Just kind of the in brief, abstract conclusions, that first part that everybody reads in the papers.
Yeah. Sure. So that 40-page paper, again, like in terms of how I framed this earlier, we have these 6 different specific research studies in mind as part of aim 2 of the overall proposal. So what we looked at was models for the hospital and the year as the unit of observation, where essentially the dependent variable in some econometric analysis was looking at how advanced of an electronic health record they have, right? And so often what we do is, I don't have much of a background on electronic health records per se, but there's a literature out there, so we kind of immerse ourselves in how do other researchers, how does the government kind of classify the level advancement of an EHR, right? So intuitively, right, you can have like generally kind of a basic one that doesn't do a whole lot, or you can have a more advanced one that does a lot. So that's kind of like what we're looking at in terms of an outcome. And we've got data across all the hospitals in the US over about a 10-year period of time. So then, on the flip side of, okay, so what are we trying to see, like what influences electronic health record adoption? So that's where these measures of hospital market concentration, right? So your local market, is it a more competitive market with a low HHI factor? Or is it a more concentrated market with a higher HHI measure? Like what is essentially the association of that measure of market concentration with the EHR adoption, right? And so in some sense, kind of simultaneously also including a measure of how large is this hospital system? Is it just a single hospital, or is it part of a 10 hospital system, 100 hospital system, so that we can turn, kind of taking a step back, right? Measure with the HHI, what's the competitive pressure on potentially hospital systems saying, what, like of course we want high quality, but maybe we're not going to be incentivized to really do above and beyond because we're in a very concentrated market, right? But then this other measure, again, how large is the system, kind of getting at this economies of scale measure. So, right, once you kind of have that set up and you're examining variation across the entire US and looking at, again, adoption of DHRs on the outcome, looking at the effect of these competitive pressures, we can document, like, 1, is it happening? But then 2, like, what's the magnitude of those relationships, right? And so, in essence, like, we documented that both of these things are happening, right? A more concentrated market is actually leading to a slightly less advanced electronic health record, which, again, I think has some clinical implications. But then on the flip side, like the larger systems, like essentially kind of measuring across individual markets, right? They actually have more advanced health records. And so in some sense then, what are the implications? Well, as you all probably know, like every merger is different, right? If you're thinking about a merger, is it going to lead to a lot of concentration? Is it just within a market? Is it spanning multiple markets? And so, in some sense, like we're kind of prepared to use these analyses to kind of describe what would happen under different situations. But back to, I think, to kind of your original question, if this is kind of like going into the weeds of doing all these analyses, 40-page paper, what we also want to do, which haven't done quite yet, there's a short summary of this work on the main page, but I think what we would like to do, and in some sense this is a place where we could especially use some thoughts, some feedback, is try and explain what we did and what we found to a less research-oriented audience. And so first pass at that is, okay, yeah, like get this intuition of a more advanced health system, and we do find evidence that market concentration lowers those competitive pressures to get a more advanced system. But on the flip side, increases in size actually do enable a hospital system to have more advanced. And in some sense, in certain scenarios, like those two effects are kind of like washing each other out. Right? So that, but again, kind of depends on the specific merger.
That's helpful, thank you. I especially want to ask you about one follow-up on one point you made, where you said sometimes the merger pressure, or the merger and the consolidation can actually cause a step backwards.
Oh,
and
sure.
I bet some of us have seen that working in it, I wonder what your opinion is on why that happens. Is it because the merging entity or the acquiring entity has a desire to own that data, or perhaps make it more proprietary and less portable if a patient moves from one system to another for specialized care for whatever reason? Does it have anything to do with that desire to keep hold of that data and keep it proprietary? Because that would be concerning to me personally.
For sure, and I think that's definitely plausible and possible, and I'm aware of other studies that have tried to kind of focus on this notion of interoperability and data sharing and the incentives along those lines. I think our initial pass at this was instead related but like slightly different, which is more along the lines of the large literature thinking about hospital consolidation leading to higher prices, right? Well, like why? Well, there's less pressure on hospitals and other industries as well, like in other contexts, of attracting patients, right? So there's less pressure to have a lower price. And then there's, follow-on literature that looked at hospital quality. And again, I think, hospitals are always kind of striving to have higher quality, but really kind of thinking at the margin, are they interested in kind of moving beyond, the 4-star hospital up to the 5-star hospital? And there's evidence out there saying that hospital consolidation actually weakens those incentives to improve quality. And so I think in some sense, like that's kind of where our lens of thinking about the weakened incentive to have a more advanced electronic health record is kind of entering, right? So if you're in a consolidated hospital market, you're not quite as concerned about attracting patients through a lower price, through a higher quality. And so I think that is then, right, you're not quite as incentivized to have this great electronic health record that does really great things for your patients, because you're not quite as concerned about attracting them in this less competitive, more concentrated market. So again, I think that's a little bit more where our head's at in terms of thinking about this, but the issue you raised about data sharing and interoperability, I think is also probably part of the story and something we'd like to try and explore for sure.
Thanks. I have one last follow-up, if you don't mind. Can you speak to the age of the data set? I noticed that it was 2008 to 2019.
Yeah.
So that's all pre-pandemic, 7 years old data. And even in 19, the paper reported that 95% of hospitals had basic EHR, so not bad, but 70% had more full functionality, hitting all 26 boxes, if you will, 26 check boxes. So we have 7-year-old data. How do we get that updated and make it more usable now,
Yeah.
post-pandemic? I mean, something must have changed. I don't know what. But.
No, for sure. So great question. And I guess I'll first try and state that in all of our research, like we're always going to strive to have like the most recent data available, right? So for the policy brief, you see with looking at hospital markets, it's examining AHA data through 2023, and the 2024 has recently been released, so we're going to incorporate that. So in some sense, these studies like will indeed like strive to have like the most recent data available. Right? So then I think great question, like, well, why did we stop at 2019 with these analyses of electronic health records? Well, short answer is that's when the IT supplement of the American Hospital Association stopped fielding those questions about these 26 attributes and does your electronic health record have them? And in some sense, you could say, well, that's kind of unfortunate why they stopped. But I think the other side of that is like, well, they stopped because by 2019, pretty much all hospitals had these 26 features, right? So in some sense, like what we're interested in seeing is like, well, what happened from 2009 to 2019 in terms of hospitals moving from having relatively basic systems to relatively more advanced. Now, most of them have advanced, but we can kind of look historically at what happened during that transition and see whether competitive pressure influenced that transition, and then in turn, make those inferences for kind of like the present day, right? So I think if one were thinking about a more recent study with data that's probably being collected and potentially distributed over the next couple years, there's going to be new ways of measuring how advanced electronic health record is, and in some sense, like we just don't have those data yet. But yeah, I mean, great question. But I think in some sense, like what we need to do, I think, is often try and make a case for why data that's 2008 to 2019 is still relevant and has implications. And I feel confident we can do that, but I think we need to make that case, especially I think in these policies.
How would you see the data that you've obtained in this study being put into effect for our commission or for, in general, for the AG to make further decisions on healthcare policy?
Yeah, so I'll say a little bit more about the data we have, and in turn kind of help you kind of understand like what the things we have in order to kind of help out. So on the hospital side, where we've probably done the most work is like there's a base American Hospital Association's annual survey. It covers all the hospitals. We're merging that with CMS data from their hospital cost reports and merging that with CMS data that some people refer to as Hospital Compare, more recently kind of called the inpatient quality reporting. So you get these nice quality measures of hospitals, and then IRS 990 data for nonprofit community benefits that the IRS has been collecting for over a decade. That's largely our hospital data. We'll have, in the process of collecting physician level data nationally, we've obtained insurer level data. So this is county level enrollment for insurers, and in turn enables us to make these insurance concentration measures. And then, I haven't mentioned this yet, we've obtained hospital discharge data for New Hampshire and Vermont, and in some sense are kind of going through and evaluating what's there in the versions we have to make the decision about acquiring Maine's data. So I haven't answered your question yet, which is essentially like, what can we offer? Well, I think in some sense, it kind of depends a little bit on what specific question you all might have, right? If it's something that's very, New Hampshire specific about patients and, what hospitals they went to and what are the outcomes, then it would be like, okay, well, yeah, we've got those data for that, and then we can kind of link that to the American Hospital Association data for hospitals and examine those kind of issues.
We want to put it out to the public. I'm not a statistician,
Okay.
okay, but as I read that, it's a very academically dense paper, and I found it hard to see, especially in regard to your question. It's not it's not new data, and CMS is now all the EMRs have upgraded to hit the boxes for this because of the pressure that's being put on CMS for all the criteria you have to meet for quality measures so that you get reimbursement. So there is, I don't even know how that would affect their choices, but they're almost pigeonholed into having to do this. But now we've got this academic exercise on EMR, it's just one small segment, and how would the Attorney General use this data in the future to make any decision on an acquisition, or how can we apply it to our healthcare population?
Okay. I see what you're saying. I think
Exactly.
the aim one aspect of our proposal is indeed meant to be more helpful to examining the trends of hospital market concentration, eventually physician market concentration, insurance market concentration on, or what are these trends and what's the variation? How does it compare regionally? How does it compare nationally? And then, as I mentioned, the aim 3 is we've amassed this data. We can help if you have specific questions that come out. But in some sense, the aim 2 is fundamentally a goal of producing a body, or contributing to the body of research that the academic community uses, that the FTC uses, that the DOJ uses nationally to evaluate mergers, right? It's this calculation of what are the potential harms and what are the potential benefits. And this draws on the academic literature that we have contributed to and aim to contribute more to.
And I'll just add that this is a very common thing that we hear, right, for a hospital wanting to join a larger system is because of the electronic health record and the desire to get a upgraded. So this is.
But sometimes it goes backwards. We even heard that, and some of us know from personal experience that it does tend to actually go, but when you said the word backwards, it really hit home. Because sometimes it does. It'll go from the industry standard, Epic, Meditech, one of Allscripts, one of those, back to a more proprietary Sunrise, I think maybe it's called, I can't remember, that's a little less portable. And so that I really wanted to drill down in, and because that could be something that's a little more actionable for us, which I think is what Dr. Cohn is looking for. But I wanted to ask you, before we run out of time, really quick, you mentioned the next 3 papers. The next one is on hospital service lines closing, and do mergers tend to cause hospitals to focus on more profitable lines? Now, to me, that's certainly not a surprise. Like, we see it in the paper every week. A couple weeks ago was CMC, Behavioral Health Outpatient, and Sleep Center, and there's a couple more after that I'm hearing are next, service lines in that same system. So I don't think that's a surprise. So I know you've got Maria Gomez tasked on that, but you also mentioned quality measures and community benefits from nonprofits. Those 2 things, speaking personally, are way more interesting than something that I perceive we already have proven, we already know, because we've seen it time and time again. So talk to me about the quality measures, that second study, and then the one community benefits from nonprofits, because that's really intriguing and something we might actually be able to help with.
Yeah, so I'll push back a little bit on the service line one, in the sense that, I've seen the stories too. I live in Exeter. I know, the ALS aspect and that Israel, shutting down certain physician services. I'm fully aware of this, right? But I'd push back a little to say, like, oh, we know that this happens all the time, right? Or this is systematic across the healthcare system, right? So in some sense, my pushback is largely that we can do this research and see the extent to which it really is happening. Like, is this happening a lot? Is this happening a little, right? Because in some sense, right, like, one could view like what's happening as some anecdotes of things that certainly happen, but not necessarily systematic across, you know, all consolidation, right? And so in my opinion, that's like the benefit from doing a lot of this research, is, you know, in some sense also, you know, not necessarily to document that something happened where it's pretty intuitive that, yeah, it probably happened, but often, you know, there's a lot of benefit, at least personally, in terms of like estimating the magnitude of this, right? Okay, this happens, but does it happen a lot? Does it happen a little, right? And so I think that's the benefit often of this kind of research. And so I'm happy to hear that you're really eager to learn what we find about the nonprofit community benefits. I've done prior research looking at these 990 data and kind of compared to the tax exemption, and there's a lot of variation across hospitals either doing a lot compared to the tax exemption they receive versus others not doing so much. So I think this is really interesting. I'm happy to hear you do too. And I think what we're interested in as the research perspective is seeing whether these competitive pressures contribute to the pretty wide variation across nonprofit hospitals we see in their community benefits. And so again, I think in turn, right, doing the research and seeing if these are systematic things that happen everywhere, if they're kind of targeted in certain specific regions, are they targeted in certain kind of hospitals, critical access hospitals, versus, you know, so I think there's a lot that can be done just to try and build the research base. To in turn, I think, you know, our case is always that this large research literature over the past, you know, several decades that academics are still kind of creating forms the basis for what Federal Congressional Budget Office, Federal Department of Justice, Federal Trade Commission, state agencies like use to evaluate a lot of these transactions.
I just want to make a couple points, just both for clarifying for folks in the audience and just to make sure that at least everyone understands, I think, our view of this. I mean, one thing that I think is important is that what this center is doing as far as, you know, research and looking at data and publishing findings, it's not necessarily meant to assist the DOJ. I mean, yes, it can assist us, but there is a lot that I think we learn when we look at these transactions. We undertake a very comprehensive investigation about the market. We employ economists, and we're drilling down pretty deeply, but none of that is public. So that is one of the things that has always frustrated us, that we can't just go out and release everything we found about a transaction after we investigate it and either approve it or block it. Unless we litigate, none of that's going to be public. So I do think one of the functions of this center that I see is that you may tell us things we already know, but you're telling the public things the public doesn't necessarily know, or other stakeholders things they don't necessarily know. And you are a more independent voice, I think, because we are the regulator and the enforcer. And when we conduct an investigation into these transactions, I mean, yes, our goal is to be objective, but we understand that the audience out there, you know, everyone out there in the world will see us as having that slant that a regulator or an enforcer is going to have. So I think even if, you know, Dr. Herring and his team is sort of telling us some stuff we already know, that's not a bad thing, because we're also informing the public. That brings me to my second point, though, that you hit, and I think somebody else hit, but that I think is really, really important. It is critical to make, I think, what you guys are doing digestible for the public. And I don't see that as a secondary consideration. I see that as really, really important. So I would just emphasize that to you. You know, once you complete these papers, once you've looked at this stuff, I think it's really critical for you to think about how do you put this in another format that academics, you know, people other than academics can understand and digest. And I'm thinking of New Hampshire policymakers too, right? We have great folks in the legislature, but we have 424 of them, and not all of them work in healthcare or, you know, have spent a lot of time on this. And we want, you know, I don't want to hand a bunch of legislators like a policy paper. We also need tools to really inform our policymakers that don't require them to dive into a 40-page paper. So, which I think for you, that means, you know, the paper is the primary source, but taking that and finding ways to put it into form that
Yes.
people can digest.
Yes. Yeah.
I just want to make sure that that is emphasized, that it's not a secondary thing, it is critical,
Yeah.
because.
No, you're exactly right. Yes, and in some defense, like, it was part of our proposal, so this is
Yep.
something we said we would do.
Oh,
right?
absolutely.
We would have this policy brief on each of the 6 more research-oriented papers.
Yep, and we want those. of
Yeah,
course.
yeah, and so, yeah, in some sense, like, yeah, we haven't gotten that out yet, but yes.
Yeah, it's not to say that you're late doing it. I just think as we're discussing it, it's a good time to emphasize how important that is.
Yes.
Because we are trying to inform the public, inform policymakers, and inform stakeholders that aren't going to be able to digest a policy brief.
Totally appreciate that, yes.
Yeah.
Thanks.
I'd like to point out too, though, that I do agree with you in Senator McHugh. I think some of the state agencies also have the ability and responsibility to take some of that more academic research and the findings and publish those accordingly too. And
Yep.
I think I can find several examples already in the outputs that are at least at this point interesting for us to maybe report at the Insurance Department's Healthcare Transparency site. I do have a question if other committee members don't mind. I read with great interest all of your research aims in the proposal. I regret the opportunity foregone to not have met you, so nice to meet you. My name's Jason. I saw aims 1, 2, and 3 working synergistically, almost in a hierarchy, where aim 1 was really the seminal, the foundational part to all this research in the program. And then aims 2 and 3, I mean, you mentioned maybe using as explanatory independent variables in a regression model. How does market share explain maybe propensity to have an electronic health record, right? But I go back to aim 1 and looking at the latency issue of the data. We're trying to characterize maybe the most current hospital market condition and market orientation with data from 2023, and I mean, even at the best, if we get 2024 data, that's 2.5 years old by the time the ink dries, and it's not really characteristic of the market as it exists most currently. And given that aim 1, I mean, a lot of the subsequent research aims rest upon the findings mechanistically and thematically from aim 1. Can you say anything about how you or your team might maybe try to overcome some of the latency issues that exist with the market data?
And can you try to do that in 2 minutes or less? Because we have to reserve at least a couple minutes.
No,
for
I
this.
get it, yeah. So, I mean, I think, you know, I'm sympathetic to the notion of, yeah, you look at this policy brief and someone could, like, at the end of 2023, and I'm kind of like, well, yeah, that's the best we could do, right? And we're kind of waiting to receive the new file, and then we'll run the numbers and we'll update the numbers. And so then you'll, you know, presumably be a little disappointed, well, it's only 2024. And in some sense, like, I can't do anything
So has your
to
team
address that.
explored any
Yeah.
surrogate approaches to characterizing the market using proxies other than the hospital discharge data?
Sorry, say that again?
Have you looked at any other alternative surrogate approaches to characterize what, I mean, people get a lot of healthcare from hospital, inpatient, outpatient. Have you looked at any surrogate approaches to characterize it that can maybe help to overcome the latency issues?
I mean, the data we have for, I forget what the name, the New Hampshire uniform discharge data we have, I mean, that's not really any newer. You know, I think we'll often kind of be mindful of understanding, okay, we have data up to 2024, what do we think has happened since then that we can't capture because we don't have the data yet. But yeah, I mean, I think we'll just kind of continuously like have this latency issue as we talk about as a limitation. But at the same time, you know, the AIM-2 studies of trying to build on this literature, and yeah, okay, like, you know, we're looking at, you know, electronic health records from, you know, a decade ago. The point really is to try and understand relationships between market concentration and quality-oriented outcomes, and then apply what we've seen historically to like what we think is on the ground now. Yeah. So I think we're always just going to have that tension that the research is looking historically.
Right, Jason, you had a quick question?
Yeah, quick question. I was listening to the data sources that you listed. I didn't hear the mass data. Have you requested and looked at the SHIA data?
We haven't yet. We can. I think part of what we're doing is trying to prioritize where we think, you know, most strengths would be, and I think some of this is also, you know, trying to think a little bit about like, well, okay, if we get mass data and main data as well, what are some of the research questions and things we'd be interested in doing with those data?
I think looking at that data is important because particularly in the southern part and the seacoast, I mean, I think there is a lot of out-migration continuing in those. And if you look at the market shares, I think the Boston hospitals have a good chunk of the market share. So if you're really looking at what the market is, I think, you know, that's probably important, something to include. And just along the lines of the transparency and communication, I'm a little surprised about the heavy reliance on the HHI. So all these papers that are going to come, they're all going to go back to the HHI, pretty much. Yeah.
Pretty much. I mean, we can do. We'll do others that look specifically at like pre versus post merger, but I think looking at the HHI is pretty conventional.
I think the public would benefit along your lines. I think maybe better understanding than what the market's definition is, because when I read it, I couldn't quite follow some of the, you know, what was in and what was out in certain markets. So I think, you know, kind of defining that to the public would be helpful, because that's important, and that's really the value of the HHI. So just a question and a comment. Thank you.
Yeah, absolutely. All right, thank you, Doctor, for being here. I think we'll want to try to have you here on a regular basis because there's a lot to talk about, as you can see. So thank you for everything. Yeah. And I would encourage commission members too. I assume you're fine with this. Like, if people individually want to reach out to Dr. Herring.
Yeah. Just
Yeah.
find my email at the center's website.
Yeah, absolutely. Thank you. Thank you. All right, I know we're running short on time. Maybe we can go a few minutes over, but I did want to just circle back to a discussion about the criteria and the guidelines. We didn't necessarily post these for public comment, but we did get some public comment, which I thought was interesting and helpful. And I would throw it open to the group as to whether we want to try to incorporate any of these suggestions. If we're going to do that, we probably can't finalize these today. But we could also look to get some criteria up and continue to revise the criteria. You know, I'm open to a discussion on this, but we didn't get any comments from commission members between our last meeting and
I was wondering what the Attorney General thought about the comments and how the letter both from Burgess and from Cohen aligned with what we have already put together.
Yep. So I think I have a couple thoughts. One is I thought that the comments made some really good points as to what we really should be looking for. That said, we wrote the statute to make sort of the permitted uses of the fund, the permitted use of the funds really broad. So I will admit I'm struggling a little bit with wanting to cast a wide net to start just to see what people are thinking, but also not lead people astray and get proposals that we would never consider. And I will say we have heard some proposals that have been submitted that I think, I would never think are the right use of funds for the fund, right? I'm not going to name what the specific ones are because I'm not going to do that to to the requesters or the folks who have reached out. So that's the tension I think I'm feeling, maybe we're all feeling. Like, I want to hear from people and hear their ideas and hear their proposals. At the same time, I thought the public comments, the two sets of comments we got were very good, and I think some that I was very sympathetic to from the perspective of what is this money really meant to do, especially in a moment where we've got this rural health transformation grant that is going to be sending tons of money out there for various things, right? We're talking about $200 million a year, and we have a comparatively much smaller pot of money that really is focused, I think, on addressing the impacts of consolidation and these transactions. Not just from an affordability perspective, because I wouldn't want to get too caught up in just affordability and pricing, but also access, right? Like, are services going away? Are there things that make people healthier that are not available, that are going away, that we could help support?
That's exactly where I think we ought to be.
Yeah. I take that back to, like, what, the more we can be addressing things or issues that have arisen because of consolidation, the better, but that doesn't necessarily just mean pricing and competition. It could mean, access and just availability of services and things that make people healthier. So all that to say, I think that one way we could go, and then I'll shut up and let other people chime in here, but one way we could go is to have the criteria sort of continue in the direction that we're going as being broad, but use some of the comments we've gotten as some kind of guideposts as we review these proposals. But I've always been a big believer in sort of a grassroots approach and hearing ideas from people, and I don't want to cut off. I don't want to write our criteria in such a way that we discourage ideas that after we hear them, we might think, oh, you know what, that actually does fit with what we're trying to do. So
Yeah,
those are my thoughts. I don't know if you're nodding in agreement, Dr. Cohen, or nodding as like.
I hear your quandary,
Yeah.
because you want to be open, and I think we've talked about this in the past, and it's come
Yeah.
out that you want to cast a broad net, and yet you don't want it to be way off base.
Yeah.
And so I think the initial criteria look that way. I think some of what we have received from public comment suggests an even a little bit more narrow and
Yep.
really focused on making a difference in terms of either quality or accessibility, and really trying to get away from any small projects that won't be. But I think we've addressed it pretty well with our criteria. I think it seems reasonable. We need to get out there and listen to the public.
Yeah.
I think that, we got to hear them. We just haven't gotten out for whatever reasons, whatever other meetings. So hearing that, I don't see any reason we can't take that in. It doesn't do anything to degrade what our ultimate use of the funds will be.
Yep.
So I think this is nice and tight and allows us to cast that broad net. It doesn't push us in any particular direction, and it certainly helps us accelerate the process. It doesn't delay getting projects in and out.
Yep.
So I'm good with this as it is, and we can revise it at will. But I think it's important to get it out there now.
Yeah.
We've got a June 26th date in there. That's pretty fast.
Yeah.
Which is, I think it's plenty of time. It's 3 months. But I think we should move on this today, and I'd move it as is.
Okay. Other thoughts?
I agree with Senator McHugh. It's a useful tool, given the tensions between the broadness of our missive and, the need to give relief to patients soon. I think it's very informative, so I would be in second of a motion.
Super. All right.
I agree, it's exactly what we need to get started and get some information flying in.
Okay.
Thank you.
All right. Well, that's sort of a vote, but I will still call for a vote. I think I agree with that, but I do want to just say I appreciate the comments we got, and just because we're not going to stop and sort of try to incorporate them into edits to the criteria, at least from my perspective, does not mean I'm not going to keep some of what was said here in mind, because I think it was helpful. And I think we will continue to just have to evaluate our criteria. And we'll see if we get 100 proposals that, 99% of them are just completely off, we may say, wow, we need to tighten up our criteria. But I think let's see. And we've got a community meeting in Exeter scheduled on April 29th, so we're going to get these in-community meetings back up and running, so that we can hear from the public.
And that'll be our third, and we'll have, what, one or two more after that, and I think we want
Yep.
to do a couple north.
Yeah, we want to go north.
But,
Go north,
yeah.
pardon.
Go.
And west, but
I'm
we've been
telling
west.
Donald, yeah.
We've been west. But we'll go west again. All right, so with that, if there are no additional comments on the draft criteria that we have, and there were a few edits based on our discussion last time, I'll take a motion to approve these criteria.
Yeah, so moved.
And do I have a second? All those in favor, please say aye.
Aye.
Any opposed? All right, and the criteria are adopted. We will get those posted, and we'll see what we get in.
So can we go back? I have a quick question for the group.
Yes.
And sort of for you too, because I'm not sure if it's possible. Is there any appetite from the group to guide or direct or encourage, whichever is the strongest, the Dr. Herring's group to, frankly, to abandon the hospital service lines, opening, closing, do merging hospitals, tend to focus on focusing on the more profitable lines? I think we know that. I really do. And I don't think it's anecdotal. I know there's headline grabbers, so it is possible that those could appear as anecdotal. But it's business 101. If a for-profit entity comes in, they're going to keep what's profitable. I think we know that. And I don't think they should waste time or money on that. They should move directly to identifying what we can do to help the quality measures, and what benefits are derived from the nonprofits in the community. Because those are things we can really help with. I really just think they should abandon that. That's my opinion. And is there any appetite from the group to guide them towards those, or at least prioritizing them differently?
I will say, I think we should definitely have a hands-on approach with them. I almost wonder, it may be, if we meet monthly, and we've been trying to meet monthly, we do have another regular meeting in April, in addition to our in-community meeting. We almost might want to have a standing time for Dr. Herring to be here, because I think we don't want this to sort of get away from us, right? Part of the intent was, we see how it's going, and we continue to talk with them about their scope. So I guess from my perspective, I think we should I'm open to discussing that. I'm not sure I'm prepared to say I think they should abandon that line of inquiry, but I think we should be continuously discussing their scope, and I want to hear from the group about that and talk, have us discuss that. But I think I'm mostly aligned with you in saying that I think we want to be hands-on with this center and what they're doing, and continue to hear from them and continue to evaluate as we go, because I think that is the way we're going to get the best product at the end of the 4-year period.
I appreciate what he said about trying to examine the extent of it.
Yep.
But I rely on Dr. Aziz to tell us how useful it is to know the difference between, we all know it's happening, we believe it's happening, to what the extent is. Is there incremental improvement by knowing to what extent, to the deep dive, right? Beyond what we already I think everybody on the street, if you ask anybody on the street, they'll just say, sure, yes, they cut the things that are losing money.
But there's some value, I think, in having an objective, sort of third party, not just say I think we know that based on what we see and hear, but we have studied it and we see that in the research. But I think there's value in that, but I think it's a fair question to ask, is the value enough that we want them to be doing that and not potentially other things?
Dr. Herring came out and asked us to guide him on
He did,
this.
yes,
And-
yeah.
And I see a myriad of
Yeah.
examples and opportunities to help them produce something that's really not just tangible, but has high utility for this group, but also the citizens. And so,
Utility.
with regards to access to healthcare, maybe we look at it differently. Instead of shutting down one service or another, or a third or fourth or fifth, something on a categorical scale, maybe we look at that concept on a continuous scale, median travel distance, instead of shutting something down. Are patients having to drive further distance on a continual scale? That's important to help him understand maybe a way to model their regressions that way would better inform our board, because there's this Kickstarter viewpoint that hospitals shall not be monopolies, but we don't have that luxury to determine that or even change much of that. But we can look at the data to see what the effect on a continuous scale is if a hospital is to be lost. And so he's asking us to inform him that way. I could see it in his eyes too.
Yeah, we should. I mean, you can look at Phoenix and Oklahoma City and some of the other big systems, Banner, that have gone through similar consolidations. So it's not unique to New Hampshire, and we don't need to reinvent the wheel or reprove a theorem here, or a hypothesis here. Anyhow.
I think what's important though for New Hampshire is that it's not just about what they may have gotten rid of, but there could have also been things that they've added to the market that we don't know about. We hear about the ones that are the services are going away, but there are benefits and mergers as well, where things. So I'm hoping that if that is the focus, that it's not just about profitability, what are they getting rid of, but they're also looking at what is happening to the market and what are they adding.
Mhm.
So I think that it's an important thing to look at.
And as a forecast too, I agree, Melissa. I heard him say a lot about the electronic health record, which I appreciate the importance of administrative tools, but it is that, and it's an efficiency gain, that too. But I am very interested in hearing from the epidemiologist on the team and modeling at least one of those research aims to see how this concept, market consolidation, impacts the health of the people. Because last time I checked, that's what the healthcare system was supposed to do, make the people that it serves healthier. And, I understand the business and the market structure and administrative efficiencies. I care most about the people, the souls, the people that have names and families. And there's an epidemiologist on that team, and I want to see one of those research aims be very focused on that, some of the key chronic outcomes that our healthcare system is supposed to attenuate. I didn't mean to preempt you.
Yeah, it was you, right? Yeah, there was a hand over there in that.
I'm still picking my vibe. One of the reasons why I said, it's a little concerning in reliance of the HHI is because the last sentence of that paper. I mean, I believe it said something like, all other things equal, a higher concentrated market could result in higher prices and quality. So it's not that simple because everything's not all equal. So along the lines of the services center, I don't know if it's profitable or not, but can there be a deeper dive as to why services canceled? I mean, it's going to fall in buckets. It could be staffing, it could be other costs which do it. It could be because of the consolidation, and in fact, we're not going to do this. It could be maybe insurance changes. So I think it would be helpful for the public to better understand why the services were canceled under various circumstances, and then they'll be able to sort of attribute it to what the cause was. But,
Yep.
so I think that's reframing what at least he had described.
Yeah. I think, I think when we initially talked about this project with UNH, we talked about wanting to have sort of an ongoing dialogue, and I think this, this period of time after they publish their first paper is a good time to do that. So I would suggest, I think for our next meeting, we've adopted the criteria, so that'll be out. Our deadline is not till June 30th, 2026, so we're not going to really be starting to review any projects at that point. So why don't we put that on the agenda for the next meeting, just to sort of look at the project we've got ongoing with UNH and talk about, whether we want to. I think we want to talk about both substance that we want to communicate to them on and with them on, but also how we go about doing that, right? Because well, I did say every individual commission member should feel free to reach out to Dr. Herring, and I stand by that. We also want to make sure that we're not all reaching out like, hey, what about this? What about it? What about that? In a way that kind of just leads to them, spinning out, right? So, but I think that would be a great topic of conversation for our next meeting is substance. What substance do we want to communicate to them? But how do we want to go about doing that and having that ongoing dialogue? Do we want to try to have them here, every month or every other month? Do we want to? Or how do we want to do that? But I think that's a good topic to try to work through in April. And if there's anything immediate between now and April, which I don't think there really will be, they're not moving at that type of lightning speed. we can figure out how to reach out to them on, but I think that'd be a good discussion for the group. But I also don't want to try to jam it into like 2 minutes, and we are over time. And I at least have to go because we have a GNC meeting at 1 on healthcare, other healthcare money. So any other,
Public comment?
yeah, we could do a couple minutes of public comment.
If there is any. There wasn't any last time.
Yeah.
We should
I
ask.
had one thing.
Yeah.
I know that there's been a lot of discussion about the rural health transformation and kind of like what that means, what their aim is versus like how does that differ from the work we're doing. And I just wanted to throw it out there in case somebody, like the committee wants to hear from DHHS and get like a briefing on what the rural health transformation is and what kind of, is moving forward with the projects that are moving forward, that type of stuff. So throwing it out there as a potential topic.
Yeah, that's a great idea, Melissa. That'd be awesome. Especially if we can hopefully get those items approved today, the GNC, and then we can have a briefing here.
Who can say?
All right, so we're limited on time, but if we have any public comment, anything that someone wants to raise, and I'm not trying to discourage it, just letting you know that if you have something to say, please say it as quickly and as concisely as you can. But please do say it. Anyone in the audience? All right, great. I fear I probably discouraged it, but I'll try not to do that in the future. All right, with that, I will take a motion to adjourn. All those in favor say aye. Aye. Great, we're adjourned. Sorry, I wasn't trying to make you make the motion. I know I was doing that.